I'd like to next introduce Professor Nichola Cooper, who is our plenary speaker. Professor Cooper is at Imperial London University, an honorary consultant haematologist at Imperial Healthcare NHS Trust here in London. And Professor Cooper is going to be talking to us about lessons from autoimmune cytopenias. Thank you.
Thank you. Thank you for inviting me to talk today. And it's a pleasure to be talking to you about haematology, actually. I'm not sure how often haematologists get invited to speak at these lectures, and certainly I'm not used to interacting with too many physicians currently. But we are important. And actually, it probably affects quite a lot of you, because our autoimmune cytopenias, for which I mean ITP, immune thrombocytopenia, is the most common one, autoimmune neutropenia, and hemolytic anemia. And the combination of all three, which is Evans syndrome, is associated with a lot of different diseases. So it is found in association with immunodeficiency states, including inherited inborn errors of immunodeficiency, suggesting that both B cells and T cells can be involved in their pathogenesis. And we're seeing it increasingly in complications of post-transplant, particularly post-Campath, and after immunotherapies you've seen earlier. It's also associated with a lot of different infections, and I was just mindful of the talk this morning talking about how important T cells are in TB initiation, and we certainly see ITP and hemolytic anemia in a number of different viruses. We see it associated with a lot of autoimmune conditions, and more frequently we're seeing it with inflammatory bowel disease, whether that's just because we're a referral centre or we're just noticing that more, or perhaps it's also to do with some of the treatments. And we see it in conjunction with our predominantly lymphoid malignancies. And I think for those patients who get autoimmune cytopenias together with these conditions, it can be a poor prognostic feature, and it often complicates treatment. And as a autoimmune cytopenias person, I think it also shows some interesting features of why people get autoimmune cytopenias. So for the rest of the talk, I'm going to talk about the most common one, which is ITP. So this is a disease of exclusion. We do not have a diagnostic test, and those of you who have had patients with thrombocytopenia after conditions may be frustrated with haematologists not being able to quite make the diagnosis. It's a rare to uncommon condition, and it has really variable bleeding phenotypes. So some people just get bruises, some people get petechiae, it can be missed for meningitis. And the most rare, but the most concerning complication is really intracranial hemorrhage. Fortunately, that's uncommon. We tend to keep the platelet count high enough to stop that. But if you do get it, there's at least a 25% morbidity. One of the features that's interesting, I think, with ITP is that it can happen at any age. So it can happen at younger age, in fact, even under 18s as well, and the under 10s, in fact, there's a male predominance. But then as you get older, there's a female predominance in the patients of childbearing age, and as you get older, that female predominance sort of goes away. So it suggests, again, there's some slightly different features. If you look at the different ages, there are variable phenotypes. So young people might be more likely to have bleeding, but they're more likely to go into a remission, they're more likely to have low platelet counts, more likely to have a treatment response, and the male to female ratio changes over time. And with adult ITP, you may be more likely to get a significant bleed because of the vasculature. You're less likely to go into remission. And as I've said, the sex demographics changes over time. The female predominance is really within that period of time where you're fertile. And it isn't just a bleeding disorder, it has a significant impact actually on the quality of life, not just of the patients, but of the families as well. And we've just been doing a body of work on teenagers with ITP and the impact that this has, not just on the patient, but also on the families. So we use this KITS ITP tool, and less than 77 suggest impaired. You can see that a lot of the children are impaired with ITP, but if they're impaired, then the parents are much more impaired. We found that the impairment is more significant in women. so in the younger girls or the teenage girls rather than teenage boys, and it does go away if you go into remission. We don't know if this is related to having a low platelet count, related to having an autoimmunity, or just related to having a chronic disease. And we asked children how they felt about ITP, and they felt really scared. They've never had anything wrong with them before. They felt like their life had changed, and they never knew how to look after themselves. So I think it's something we have forgotten a little bit about, is actually you might not die from this condition, but it has a significant impact on your life. And we also found cognitive changes, both in children and in adults with ITP. So we use a CANTAB pad-based test for people, which is quite a simple test to do. And we were surprised in finding almost 20% of patients having impairment in episodic memory, about 16% impairment in executive memory, processing speed, and working memory. And a number, almost 40% of patients were depressed. So we wanted to look at that in a bit more detail, and if you have a current study where we're looking at microbleeds in patients with ITP, we've identified that at least half of patients with very low platelet counts have tiny little bleeds in their brain, and surprisingly, a number of them also have white matter lesions in their brain. And we're looking to see whether that contributes to cognitive impairment. And our surprising finding in this micro MRI brain was really these white matter lesions. So bleeding might be obvious for a low platelet disorder, but actually one of the things that causes significant impact for patients is actually thrombosis. And certainly our preliminary findings suggest that that would be more likely to be causing cognitive impairment. And I'm a haematologist. I had to show a film, blood film here. You're expecting to find that platelets are tiny little things that you can hardly see. But actually in patients with ITP, they have really big platelets, almost the size of a red blood cell. And one of the things you want to understand is whether these big cells, and ITP patients have much bigger platelets than normal platelets, whether they're more activated platelets, and perhaps they're contributing to the thrombosis. And from lessons from ITP, we also found that in patients with COVID-19, there is ITP as well as there is thrombosis. And we did some work with John Gibbons and Reading, looking at the fact that actually anti-spike antibodies can activate platelets and cause thrombosis and a lot of the inflammation that's occurring. So what else do we know about ITP? So this is just a summary slide of the biology and treatment of ITP over time. So ITP first came out in a paper in the 1920s when a medical student took out the spleen of a person with ITP, and it worked. And actually for the next sort of 80 years, actually splenectomy was the prime treatment for patients with ITP. Works in about 70% of patients, but for 30% of patients, they no longer have their spleen and they still have ITP. I'll show you an experiment from the 50s, which was first looked at sort of antibodies, identified antibodies in ITP. IVIG was first used in the 1950s as well, and this was again serendipity. So the common variable immunodeficiency clinicians who started using IVIG for patients with immune deficiencies noticed they stopped getting ITP. So that was why IVIG was first used for ITP. It's now used for a lot of other autoimmune conditions. We then started using azathioprine, MMF, vincristine, and danazol. And then 2000s, we borrowed rituximab from the lymphoma doctors. So they first started using anti-CD20 rituximab in lymphoma. We started using it in ITP and a lot of other autoimmune conditions. T cells is a lot of work we're doing, and people started looking at how can T cells or antibodies cause of ITP, and also understanding the megakaryocytes through the biology of actually sort of platelet production. And in 2010, we've started using thrombopoietin receptor agonists. So TPO receptor agonists can make your platelets or megakaryocytes produce more platelets, so not using an immunosuppressive for an autoimmune disease. And then finally, we've now started using SYK and BTK inhibitors, which are finally licensed for ITP. So having had nothing but splenectomy till 2000, we now have a plethora of new treatments which are also used in other autoimmune conditions. So if you think about the biology of ITP, here is a megakaryocyte, a very large cell in the bone marrow producing platelets. It was initially thought to be an antibody-mediated disease, and these antibody-coated platelets are getting recognized by the macrophage, destroyed in the macrophage through signaling through the SYK pathway, presented to T cells. But what's not clear still is how much the B cells are involved or T cells are involved. And certainly we've done some work to suggest that it's not just an antibody-mediated disease, but perhaps cytotoxic T cells killing platelets, but also killing the megakaryocyte. And so treatment is aimed at preventing platelet destruction using IVIG, inhibiting T cells using steroids, MMF or azathioprine, stimulating the megakaryocytes to produce more platelets, using B-cell depletion, using rituximab, or inhibiting SYK and BTK pathways to prevent platelet-mediated destruction. And there are a number of other treatments now in clinical trial. So I'll go through a few of those and a little bit of how much we can understand biology around treatment or treatment responses. So you may or may not know that actually we don't know a lot about how platelets are regulated. How do you know how to produce more platelets? How do you know how to have platelets of 150, 160? We don't fully understand that. So megakaryocytes in your bone marrow have to get to the endothelial vessel wall. They pop platelets into the blood vessel wall. As the platelets get old, they start losing sialations, losing sugars on their platelets. Those old platelets then get recognized by the atraumoral receptor in the liver, and that recognition and that destruction of platelets triggers the liver cells, Kupffer cells, to produce more thrombopoietin, which is the principal regulator of megakaryocyte production. Although this hasn't been replicated, and I think there's still some parts of this pathway we don't fully understand. From an ITP point of view, thrombopoietin levels are not raised, so although you have a low platelet count, you do not have an increase in thrombopoietin. And so you're getting this enhanced liver platelet clearing. Whether you're missing this part of it, I think, is another quick question, but you're not getting an increased level of thrombopoietin. So the newest treatments, and certainly I think it's a helpful treatment for patients who are otherwise immunocompromised, and some of you may have seen that in your own patients in either immunodeficiency states or post-immunotherapy. We're using TPO receptor agonists. There's three different ones. One is romuplastim that activates at the same site as the native thrombopoietin. Two are small molecules, eltrombopag and avatrombopag, that act at a slightly different time point. Eltrombopag has a lot of food restrictions, and so we're now tending to use avatrombopag, but I'll also talk a little bit about why you might use one rather than the other. And they all make the megakaryocyte produce platelets. So they have been transformative, they have really helped us, but actually still only 50 to 60% have a good durable response. They have to have frequent blood tests. There is an increase in thrombosis in those patients. Some people lose response, and really importantly, for some people, they have wildly fluctuating platelet counts. And perhaps actually for some patients, we do need to actually look at their autoimmunity. So this is the dogma of ITP, is that you get antibodies coating platelets and they then get destroyed by macrophages. And how do we know that? So in the 50s, a medical student called William Harrington injected himself with plasma from a patient with ITP, and he dropped his platelet count for about 4 or 5 days. Fortunately, it came back up again, and he injected a number of his other mates, medical students as well, and they had a lot of them had a drop in their platelet count for a period of time. We can't repeat this now, unfortunately. But notably, this looks like it's all an antibody-mediated disease, but point actually, we don't have a diagnosis. So those people had thrombocytopenia, and certainly I think it's an indication that for at least some people, antibody-mediated disease is part of their ITP. We did borrow rituximab from the lymphoma doctors in 2000, and we've shown that rituximab does work in ITP. but only in about sort of 50% of patients. There are better responses if you give it in the first year of the disease. And we found where the patients we first gave rituximab to had ITP for greater than 15 years. Many of them, they were quite really heavily refractory. Possibly better responses in women. Most people will relapse, but most will respond to retreatment. And actually, I think it is well tolerated. There's been a lot of anxiety around rituximab during COVID, and should we be avoiding it? But actually, it's a very well tolerated treatment. And moving on in antibody-mediated disease, so the next new treatment is something called fostamatinib, which is a spleen tyrosine kinase inhibitor, which is a targeted treatment for ITP because actually it inhibits the macrophage-mediated destruction. It reached its primary endpoint. It was better than placebo, but probably it doesn't look very effective. Only 20% of patients really are having a stable response compared to control. But those are very heavily pretreated patients. Really importantly, there are no thrombotic events in these patients, but there are adverse effects. So some patients get diarrhea, increased blood pressure, and increased infections. So it's a good first SYK inhibitor, but I suspect hopefully there will be new, better SYK inhibitors. And we're now trialling bruton tyrosine kinase inhibitors, so which are downstream again of the SYK pathway. So the macrophages need SYK and BTK to be able to destroy platelets. They also, activated B cells also use the SYK pathway. So it's a really targeted treatment potentially for ITP and other autoimmune cytopenias. They're being trialled in many other autoimmune conditions now. Again, response rates, this is in the phase 2 study, about 40, 30, 40%. So there's still a cohort of patients who are not responding to treatment. One of the really exciting things, though, is that actually people felt better. So they feel less fatigued, they feel less tired, and it's the first treatment really to measure and actually show an improvement in quality of life in patients. And for both the SYK and the BTK inhibitors, there have been no thrombotic events in the clinical trials, which is compared to 6 to 12% in thrombopoietin agonist trials. And this may be because actually B cells, macrophages, and platelets also have SYK and BTK pathways. So we may be actually correcting a platelet pathway abnormalities by inhibiting BTK and platelet activation. So I think this area is really interesting, and we're now doing clinical trials to see if you really can improve quality of life in these patients. And then finally, actually response to B-cell targeted therapy is not that great, between 30 to 50% of patients. Do we need to give it earlier? Do we need a different target? Or is there something else destroying platelets? And there's a number of different B-cell inhibitors in clinical trial. We're running the BAFF receptor inhibitor, CD38 inhibitors, and we're waiting to see if that gives you a better response. But we've also been trying to look at other methods of platelet destruction. So even with the best in-house laboratory test of antibodies, up to 30% of patients do not respond to do not have detectable antiplatelet antibodies. So we wondered whether actually T cells were also killing platelets. And so we started to look at the cytotoxic T cells, see if they could also destroy platelets. We've identified these CD8 TEMRA cells, so we see them in ITP as well. There's no correlation with infection. These patients were not obviously having CMV or EBE infection, but we certainly found patients with increased TEMRA cells, so these 45RA positive, 62L ligand negative cells. And when we look at the T cell receptor repertoire using deep sequencing of the T cell receptor, we found a reduced T cell repertoire in patients with ITP. The repertoire follows the platelet count, so at low platelet counts, there's a low diversity. As your platelet count improves, the diversity improves. As the platelet count falls, the diversity falls again. And this was associated with really expanded T cell clones. So in patients with more refractory disease, they have these expanded single T cell clones and compared to responsive disease. We identified these T cell clones were within the TEMRA population, looked using combined TCR and gene expression sequencing. And we've been following these platelet count, these TEMRAs over time now. So if you isolate the TEMRA cells, we can identify these single expanded T cell clones And at each time point where this clone is expanded for this patient in a 5-year period occurs at the same time as the platelet count has dropped. If we culture CD8 T cells together with these platelets, so your platelets and T cells there, we've shown that those cultures show increased 107A, so activation of T cells, and evidence of T cell lysis, so implicating that actually T cells may directly kill platelets. What does that mean for therapy? So mycophenolate does work. So this is a randomized controlled trial of mycophenolate that we used in patients with ITP, but it's actually pretty poorly tolerated. We also found similar response rates in patients with L-trombopag. You can come off treatment. And actually, in some patients who don't respond to romaplostim do respond to L-trombopag, even though it's acting supposedly in the same way. And actually what we know about L-trombopag is it's an iron chelator. So we wondered whether perhaps the anti-proliferative effect of iron chelation could also be working in T cells. And we have found that L-trombopag can inhibit the proliferation of T cells through cell cycle arrest. So perhaps you can have a dual activity of increasing your platelet count and killing off the most reactive platelets. So what's the future? So actually, the future looks kind of bright but kind of confusing. All of the things in orange are clinical trials that are ongoing in ITP, so really we have to be able to direct treatment, understand the disease better so that we can work out which treatment someone should have, but there's no T-cell directed therapies. We are looking at genetics of patients with ITP. We've found a lot of variants of unknown significance, particularly in T-cell mediated disease. And this is particularly important, so if you go back to the patient, this is a patient who was diagnosed with ITP at 5, hemolytic anemia at 7, became hypogamma at 11, having had both rituximab and splenectomy, developed gastritis and enteropathy in his 20s, and actually was then diagnosed with a CTLA-4 heterozygous variant and is now on a Bataset. So genetics will help us in the future. We are using single-cell sequencing to subcluster T cells and iron and B cells, see if we can identify different types of cells, and finally CAR T cells. But are they going to be the cure of autoimmunity? I did read that in the newspaper yesterday, that we're all going to be cured of autoimmunity, it's totally fine. But actually, we're also finding complications of CAR T cells treatment. And if it goes wrong with CAR T cell treatments, we get prolonged thrombocytopenia, which also helps me to believe that actually in some patients it's a T cell mediated disease. So in summary, we do get autoimmune cytopenias, complicates many different autoimmune disorders. It's a very heterogeneous disease. While we do have different treatment options now, we need to better understand the underlying cause so that we can better direct treatment. We do need better T-cell directed therapies that don't make people feel unwell. And I think the role of CAR T-cell in autoimmunity is now being explored. I just want to thank my team who did all of the work for this, our collaborators both in platelets and radiology, and also particularly our funders, which have mostly been charity, the ITP Patient Support Association, John Moulton Charity and Rose Trees, but also now the NIHR and British Heart Foundation. And thank you for listening.
Okay, we have time for one question. Yes, please.
Why do the kids get away with it?
Well, yeah, they don't always. So I think there's two different parts to that. So I think the under 10s, it's probably just a viral mediated ITP, thrombocytopenia, that it goes away. And so I think we're counting that as ITP, whereas it's actually just a post-viral thing. Whether there's T-cell complications, it seems like we have more T-cell complications in the older adults, so I think it's probably a slightly different disease. It's not just one thing. So you have a low platelet count, but actually there's so many different things that can cause it.
Thank you so much, Dr. Cooper, for your excellent talk, and we're now moving on to the flash posters.